I forgot today that you don't access
Do you want me to take
dialysis
Are you
boards.
ready?
it? Yeah, we're fine.
Did you do it? No, but I was just like, don't worry
I
about
got
it.
training on
So-
blood and everything.
And then they're like, we don't access that.
So quick synopsis, like pick lines, kind of lines, okay, anything else not really access.
If the port has already been accessed, they put the needle in there, knock yourself out, just clean your hands. Like that's safe. I just would be careful about being the one that's
Yes,
sticking the needle.
No, I can do
You just say
that.
clean your hands when you're wearing blood, like clean blood, figure, kind of like a dumb question.
No, not dumb at all. Officially, it means removing your gloves, doing hand hygiene with a hand sanitizer, or if they're soiled, washing them, and then donning a clean set of gloves. And then remembering that those are still not sterile, so when you're scrubbing, you're trying not to touch the tip, and then you're hooking up. But officially, just changing blue gloves is not sufficient. And blue gloves are still contaminated. It's just they want them to be clean. So what they want to avoid is like the nurse goes in and helps you, assist you with the urinal, and then takes those same blue gloves and gives you a dose of Zofran in your central line. That's bad. You don't want the bugs from down there going inside. No. All right, blood transfusion very quickly. So the objective is to review the protocols, identify the patient that needs a transfusion, match the product with the patient, discuss the risks, and identify transfusion reaction. So the Montana protocol says that you're supposed to put them on oxygen and maintain that, put them on a cardiac monitor, and reassess them every 5 to 10 minutes. And they want you to collect EKGs and the transfer sheets and all the other stuff. And if you're going to infuse the blood, they want you to contact medical control. Now, if the sending facility says, we think you should give some blood, I think that constitutes medical control, and you don't need to call the receiving facility as well, all right? Especially because the sending facility knows the patient better, right? So if they send you with 2 units and say, please give these, I think you're good, all right? They want you to document the blood bank number. There's a W and then a bunch of numbers after that. That's the blood bank number. And keep the bag with the patient. Put it in a red bag, a biohazard bag, and then transfer that with the patient, turning that over to the receiving facility. Usually though, it won't be in the red bag. It's going to be up on the pole. That's how we know the blood's done, because it will be empty. All right, so you're going to instruct the patient to report any dizziness, chills, chest pain, restlessness, nausea, headache, dizziness, anxiety, or dyspnea. Yeah, right. Just let them know you're giving them some blood and monitor your patient every 5 or 10 minutes. Okay? Watch for signs of a transfusion reaction, which is frequently flushing of the skin, cyanosis, sweating, bradycardia, tachycardia, hypotension, or distended neck veins. We will get into what are the most common adverse events in a minute. If the transfusion reaction occurs, they want you to discontinue the transfusion, save the remaining bag of blood, physically disconnect the line from the patient, maintain an IV with normal saline, notify medical control, and then they want you to draw a blue top. I think this is cute because nowhere else in EMS are we drawing blue tops, but apparently here we are. But maybe draw a blue top and then treat any hypotension with normal saline, okay? So the other thing I would tell you is the first void of urine, we sometimes test. There's something in the urine that the lab can pick up to say whether they've had a transfusion reaction. But the more common test is of the blood. All right, so who needs blood? That's a huge list of who needs blood. Forget about all that. Yep.
Thank you.
Thanks. So don't worry about that list. You can look it up later if you want to. Somebody's going to tell you if the patient needs blood, or they're going to have some symptoms we're about to talk about. So the practical EMS indications for a transfusion are signs and symptoms of inadequate oxygenation of the end organs. You already know what that is, right? That's your ACLS stuff. Altered mental status, pale skin, dizziness, chest pain, shortness of breath, that stuff, right? The things you would do ACLS for. So if they have those signs and symptoms, and you know that they're anemic, or suspect that they are and you've got blood, then you would give it. Chest pain or EKG changes. I took care of a patient once that had a GI bleed and had a VF arrest. Well, why did he have a VF arrest? Because he didn't have much hemoglobin anymore and he wasn't supplying his myocardium. He had kind of a low flow spot in one of his coronaries, and then suddenly when he wasn't moving oxygen around as well, he basically failed his stress test and went into a VF, okay? So people can get EKG changes up to and including ventricular fibrillation from anemia. Known anemia per thresholds. So you know the patient has a hemoglobin of 5, you're going to give blood. Typically the transfusion limit is about 7 for the risk benefit. Ongoing blood loss, right? So they had a hemoglobin of 8, but you're looking at, a liter of frank blood in the Foley catheter. Well, it's not in the patient anymore, so we better put some more in there, right? So if you know they have ongoing loss. Hypotension requiring more than 1 liter of crystalloid. So American College of Surgeons just changed their guideline for trauma management. Used to be 2 liters of crystalloid, then switched to blood. Now it's only 1 liter. So I would argue that any patient that's requiring volume, by the time you get to them at that outside hospital, they probably need blood, right? They shouldn't be getting any more crystalloid because they probably got some crystalloid from the other EMS agency. You know they got at least a liter in the hospital, right? Because everybody gets a liter or 3. And by the time you get there, you certainly don't want to be hanging another liter, all right? So hypotension in the trauma patient after a liter of crystal. Or if the Foley shows less than 30 mils of urine output, that's kind of the least specific of all of those, right? All right, so scenario, 84-year-old female presents with hematemesis. She's at an outside hospital that's vomiting blood. 2 hours away, blood pressure 140 over 100, pulse rate 110, respirators 30. 1 episode of hypotension. Remember I said ask about the worst vital signs. So at one point she had 80 over 30. She's diagnosed with an upper GI bleed. History the same with banding endoscopic previously. She's got 2 peripheral IVs, hemoglobin of 8, down from 11 last week during her outpatient visit to her primary care. So they're sending 2 units of ONEG with your ALS ground ambulance. The reason for transport is a GI consult, and they're going to go to an inpatient medical floor. So, any questions? Temp, good question. She's not septic today. Good. All right, so en route, she has 3 episodes of coffee ground emesis. The patient's now pale, cold, and diaphoretic, complaining of chest pain, and the GCS went from 14 to 11. Do you think this patient needs blood?
Yes.
Yeah. Okay, why? Because 1, we saw it come out of them, so we know it's not in them anymore, right? And 2, she's got every bad end organ thing you could think of, right? So BP times out twice and then reads 60 over 25, all right? So what to do? What are you gonna do about that? We already said we were gonna give the blood, right? Cool. What else are you gonna do? Call, right? Because is this patient appropriate to go to the floor?
No.
Hell no, right? So they need a scope, they need it yesterday. But we definitely don't want to drop this person off and have them not in a critical care area. Good. So if you started 2 units of ONEG, the patient stabilized. If you just gave fluids, the BP increased and then dropped, and she wound up with renal failure. Remember that the hemoglobin are what moves the oxygen around. So if your hemoglobin is like 4 or something, 12 being normal, then that's the equivalent of barely breathing, right? So you can look at their SAT and say it's 100%, but if their hemoglobin is 1/4 of what it should have been, that's like a SAT of 25%. How many of us would allow a SAT of 25%? None of us, right? So if you've got low hemoglobin, that's the same as you not breathing well. You got to do something about it. If you did nothing, the patient goes into VFib arrest and converts to sinus tach after 2 minutes of CPR and some epi. Why is that? Because all she needed was a little squeeze, right? And did you call the receiving facility, and who did you talk to, and what did you say, right? We all already decided that we were going to go to a ICU or an ER, someplace big and safe. All right, blood types. It's really late, and I don't want to get into a lot of detail about this, but as we all know, patients have different blood types. Emergency blood is going to be O negative. That's going to be the universal donor. And that means that they do not have the Rh antigen, so you're not going to have a reaction there. And type O blood does not have any reaction with type A or B antibodies, so it's the safe universal donor.
What does low titer mean?
Let's go back here. Where are you seeing low titer?
Well, that's like all the rage right now, low titer, whole blood.
Oh, I think they're referencing just limited antigens on the blood. There's a graph, this is a graph of who can get what kind of blood with recipients and donors, and the blood bank works this all out, and as far as I'm concerned, it's a black box, and I just do what I'm told, right? But if you want to geek out on it, there's different incidence rates of reaction with different types of blood that you're mixing across different patients. And then type A and B and O, those are just general terms, and then within those there are still other antibodies, and there's things called cold antibodies where there's like just a little bit of a reaction. And so some patients are really tough to get a blood type on because they have some of these more subtle antibodies that could cause a reaction. So even like O-neg blood or type and crossed blood that's the safest we know how to give could still have some things in there that you would react to because we can't run every test for every antibody every time. So some of it is also based on history. Like if you have a history of having cold antibodies, then the lab will trigger a much more detailed assessment before they issue blood products to you. But that equates to wasting a lot more time before I can give you type-specific blood. So it's kind of a trade-off. So my guess is low titer is just stuff that's the least likely to react. So blood typing, it's going to be handled by the lab. Uncrossed or O-neg blood, sometimes O positive. O-neg is the universal donor. It's not going to have any antigens and there's no RH, so it doesn't have a lot to react with. It does still have a risk for reaction because there are those subtle antibodies that we don't necessarily know about. AB is the universal recipient because they have no antibodies in them, because if they did, they'd be attacking their own blood. And there's lots of possible combinations with various rates of reaction, right? So ultimately, what I'm looking for is when the blood bank issues it, it's going to say on the bag, this blood is for Trenton Harper, this is his date of birth, this is his blood band number, okay? And what I'm looking for when I double check this is that really Trenton that I'm putting this bag of blood into? Is this his date of birth? Does this match the band number on him? Okay. If those 3 patient identifiers are correct, then I trust that the bank did its job as far as which type of blood to give him. Okay. Because there are so many possible combinations. You can also have alloantibodies from pregnancy. So if a woman's carried a fetus, she may have antibodies against that fetus, and that can change your blood type actually in some cases. Trivia, if you're like in a mass casualty and you have O-neg and O positive blood, you'd always give the O-neg to the female because you don't want to take a female and make her positive if she's negative, because if you convert her to positive, she can have a higher incidence of miscarriage and pregnancy complications. So males, of course, don't have that concern. So if I have only 1 unit of O-neg blood, it goes to a woman of childbearing age, and the positive can go to a male, because if I make you positive, if you were negative before Trenton, and I'm just saying if, and I give you some positive blood, you might be a positive, but it doesn't matter. So, good to know. All right, risks: infection, allergic reaction, volume overload, hyperkalemia for multiple transfusions, renal failure. Risks of infection, this is just straight off the CDC. Basically, the infection risks are virtually 0 because we screen, but we can't test everything. So there's a risk, but it's very, very low. Reactions to blood, you could have non-hemolytic, which are the most common. So the non-hemolytic, you're just going to have some minor chills and fever and some shortness of breath. That's not going to progress to full anaphylaxis. They'll be okay. All right. So just because the patient starts to have a couple of symptoms doesn't mean anybody did anything wrong with the blood. Anaphylaxis occurs in somewhere between 1 in 20,000 and 1 in 50,000. And the most common reason for a blood reaction is the wrong blood going to the wrong patient, which is why we use 2 people to make sure we see those 3 identifiers. And that's for typed and crossed blood. If we don't have typed and crossed and we're just giving emergency release or O-negative blood, then all we're double checking is that this is indeed O-neg blood. We just look and say, 2 people say, yeah, that's O-neg, and this is an emergency in which we've been ordered to give it, and then we give it. All right?
Mark, dumb question. So the type, when you say type and cross, sorry.
Yep.
Typing is the blood type, the cross is...
Type and then cross-check against the
Cross-check,
product you're
yes.
giving. Yeah, sorry, that's just like,
Good.
yeah. So typed and crossed or type-specific are the terms we usually, and that just means the bank has gone through that process and double-checked everything to the best of their ability. Emergency release is what we give in the ER when we don't have time to wait for the type and cross. And then you can have a delayed hemolytic reaction all the way out to 30 days. But that's really not your EMS concern. Your EMS concern is, are they going to have a reaction right there during the initial transfusion? So to identify allergic reactions, you're going to do vitals every 10 minutes. That was in the state protocol anyway. Add temperature to your vital signs. Most of the protocols in the hospital are that if they increase by more than 1 degree centigrade, then you'll DC the blood transfusion because there's a concern that they're mounting a reaction. It's purely based on your clinical impression as to whether it's an allergic reaction. Okay? So the most common symptom that you're going to see is a sudden rash with some angioedema or wheezing, flushing and itching. I've never personally seen one of these, but I'm told that patients will frequently writhe around and have these like really obvious reactions very quickly, right at the beginning. And those are the ones where you're going to turn the drip off right away. So the danger signs are when that progresses to shortness of breath, cyanosis, abdominal pain, and hypotension. And that's when hopefully you, if you haven't already done so, turn the darn thing off and disconnect it.
And is that alone going to fix the problem?
It's going to reduce the problem. And then you're probably going to give a couple liters of saline to increase because you got massive vasodilation at that point.
Yeah.
And you may consider epinephrine. But volume and turning off the blood are the main treatments. Yeah. Stop the transfusion, follow your anaphylaxis protocol, presumptive high flow oxygen, don't hesitate with the epi. You can anticipate giving 1 to 2 liters of saline. And you can do albuterol for bronchospasm, save the bag, and there's going to be further testing. And again, doesn't necessarily mean you did anything wrong, but obviously you don't want to give the rest of that blood. So practical tips for administration, you're going to use 2 people to confirm name, date of birth, and blood band number, or the fact that it's O-neg and we're choosing to do that. If the blood is incompatible, blood is incompatible with all other medications. The one other thing that you can run it with is saline, and that's because we prime the tubing with saline, so it's okay to run it with a little saline. But hopefully you're not giving saline, right? Because you already gave that 1 liter crystal, so we're giving blood. Saline is the priming fluid, not LR. LR is not compatible with blood. So if you're out with a trauma patient, even in the pre-hospital world, and you're gonna be one of those super cool medics and stick the blood tubing on there, stick it into a bag of saline. If you stick into LR, it's useless. You've got to start over anyway. If they're not in extremis, meaning they're not dying in front of you, then we want you to start the transfusion at no greater than 100 mils an hour. And the reason for the first 10 minutes. And the reason for that is we would like to know if the patient's going to have one of those big bad reactions when they've only had just a little bit of the blood instead of wide open ripping it in there. Now, in the case where they're in extremis, it's going to be darn hard to identify, is this hypotension because they're bleeding to death or because they're having a blood reaction, right? So, you're just going to have to look to clinical signs like rash and some other stuff, okay? But ideally, slow transfusion for the first 10 minutes, then you can open it up. Escalate the rate up to and including max and wide open with a pressure bag. And you can follow one bag with the next one. You do not need to flush between bags. We don't want to flush between bags every time because you're giving too much crystalloid to flush clean. So this is a depiction of the primed chamber and giving the blood. There are other blood products which you may be called upon to administer. Fresh frozen plasma typically comes in a 4-pack, and what it's going to do is correct coagulopathies. And it's especially sometimes for blood thinning medication. So if they have a high INR for some reason, we'll sometimes give a 4-pack of FFP to lower the INR. Platelets can reverse or partially reverse Plavix. So you might be called on to give a bag of platelets. Platelets are really precious and sometimes they're not available in these smaller facilities, so that might have to wait. Cryoprecipitate is basically a bunch of clotting factors. It's a piece of the blood, so we're not getting whole blood. So we pull a certain amount of blood out of you, they put it on a spinner, and then they pull the blood into different parts, and the cryo is all the clotting parts. So if a patient is bleeding and getting multiple rounds of just packed cells, we'll give them a dose of cryo because they need that extra clotting factor to be able to make clots and not bleed to death. So you can give FFP platelets in cryo through the exact same tubing. You flush it all with saline. You can follow one to the other. It's not going to hurt anything. They were all in the same bag at one point in their lives. They just got separated out in the blood bank, okay? Platelets, if you can, you want to avoid pressure bagging because you'll break the platelets and then they're not as effective. So just let those go in by gravity. But the cryo and the FFP, you can do pressure infusion if you need to. And then at the very end, you're going to flush everything clean with the saline. All right. Very, very quickly, has anyone actually spiked blood? One of the medics want to come up here and do this? Okay. And everyone else can just watch and we'll get you guys out of here.
Hey Marcus, can I ask you a question?
Absolutely.
Just to the crew, I have the Red Cross has been wanting to set up a blood drive at Messi. And I'm just wondering if we did that, I think we have to get 20 employees to be a part of it. It wouldn't be until November or December probably. Is there anybody in here that would partake in that or help? Okay, I think we can get enough of those, right? Okay, cool. Thank you.
I would bleed. I wouldn't handle with the rest.
You're definitely getting here.
Okay, so you're going to prime with saline, and then you're going to give the blood.
So prime the saline first.
Yep. And he already did the right thing, because I think he's probably done this before, but you want to make sure to clamp this one off so that your saline doesn't just run out the other hole.
Did you do that on purpose? Is that a mistake? Did you do that on purpose?
I don't know what's next.
And then you notice that his roller clamp down here, so he's going to open his roller clamp on the top, and nothing's going to flow because this roller clamp is still locked. What you want to do is squeeze this chamber, and you want to get this chamber full. Now, if you get the chamber completely full, you won't be able to see your drip rate, which sucks. You can't tell if it's flowing. But ideally, you want there to be fluid covering the filter. You don't want the red cells falling and splashing and impacting onto the plastic. You'd like them to land in a nice, gentle puddle of saline. So I really don't like this transfusion set because the filter is so tall. But ideally, you're not dropping all of your cells, especially your platelets. Okay, so a nice little bath of saline, but not so full. And unfortunately, the Goldilocks distance here is not very long. So now that that's full, I'm going to open this up, and I'm going to prime the rest of the line with the saline. Okay, so now it's dripping, or it will be. Good. And at this point, he's going to lock off the saline. Really important to lock it off. If you forget that step, you're going to make Kool-Aid. The blood will backflow instead of going down, it'll go into the other bag. We've all done it, but it's embarrassing. All right, so now he's ready to administer his blood, so he's going to spike into his blood.
What does the filter?
I think it's clot, and there shouldn't be any. They just want to make sure you're not infusing a little PE.
Makes sense.
Good.
Yeah.
Giving,
Good thought.
at what point are you all giving calcium?
Yeah, so we presumptively give 1 gram of calcium for every 2 units of red cell. And we will occasionally, this is off-label, we will occasionally slow push it over 5 to 10 minutes out of an ampule. So the time you need to think about that if you've given more than 2 units of red cell, I would call med control.
It would have to be another line, right?
What if you
It
don't?
would be in a
get calcium?
dedicated line. And so we have calcium chloride on the trucks, but officially calcium chloride is infused over 60 minutes on a pump because it is a medication that can cause hypotension, and typically you don't infuse things with pluses or minuses like potassium very quickly. I will tell you that anesthesia infuses it in about 5 or 10 minutes, slow IV push into a separate line, and there's rarely any problem, but that's all med control. That's not going to be protocol based. Okay, so he's ready to administer. So he's opened up his thing, and now I'm going to open up my roller clamp, which is attached to the patient. And what you're going to notice is if you've got the clamp right, it won't go back that way, and you're going to start seeing the red, and you see how it's
Awesome.
starting over there. Okay. All right, so watch the red as it goes down the line. What I do is I continue infusing. See how it's becoming more red? And with real blood, it's even more obvious. But then I slow it down to 100. But I make sure that at least a little pink is in the tubing before I start my 10-minute clock. Why do I do that? Because I don't want to see what happens with 10 minutes of infusing saline. There's barely been any red cells touch the patient, right? So I want 10 minutes of a few red cells going in before I then open up wide for the rest of the red cells, okay? Now, when you're done transfusing, you're going to notice that the entire line, this bag is now empty, imagine that, and you're going to infuse saline to blow the rest of that blood through. Because that's not an insignificant amount of blood. That's like maybe 15 milliliters out of 300. So, I'd like to have it. But don't infuse this saline
Into the blood bag.
into the blood bag. Don't do that. And then also, don't expect that this line is going to become clear. It's not. It's going to be pinkish, and that's the best you can hope for. But remember, it was only 15 mils of blood in the tubing. So I don't want to infuse half a liter of crystalloid and dilute out all that fresh, wonderful blood I just put in the patient with another unit of crystal. So just flush it a little bit and know that this line is going to be a little bit pink tinged, and that's perfectly fine. It is what it is.
Is this, not that you would do this, but is this compatible with 3%?
I don't know the answer to that. Officially, you would not do that.
Right.
Yeah.
But once this is done and you can hang another bag, you just put the bag
You
in your
chase
bag.
right after it, yep. And then the other thing, if I had FFP and red cells, ideally I would alternate FFP and red cells back and forth. And the theory there being, I don't want to push all of my red cells in there while my patient is coagulopathic and doesn't have the clotting factors they need to make clots, because then they're just going to bleed it right back. I'd rather give a little bit of clotting factor in the FFP so that they can form some clot, and then some red cells behind it, and then some more FFP, and then some red cells behind it. So you have what's called a balanced resuscitation. So same for platelets and cryo. If you happen to have them, you'd want to give those first, or at least somewhere along the line. You wouldn't give like all of the reds and then some of the FFPs and then finally the cryo. You'd give the cryo first and then the reds. So, questions?
I got
All right. Yeah.
I'm sorry. So for the standard paramedic non-critical care,
Yep.
are we allowed to do all aspects of blood products? So FFPs, platelets, cryo, and blood, or is it just
It says blood.
Products.
Yeah. And so, the military, all of the wonderful things that they've had happen with blood, or because the military typically uses whole blood. And yeah, blood product's a blood product. So the risks of anaphylaxis or allergic reaction to FFP, cryo, and platelets are virtually zero. All of the antigens are associated with the red cells. So I'm not saying it could never happen, but it's just like super rare. So really most of the risk is through the packed cell. And that's also the most common transfusion that we would give. But yeah, my understanding of the protocol is all blood products.
And say some facility does give you some blood products to give in route.
Yep.
If they give you multiple bags, should you hang the one, put one in your refrigerator, or what are we doing? Do we leave it
Yeah,
out?
the frozen plasma, when they give it to you, it's frozen.
Oh, you got it.
So the frozen will be warmed.
Okay.
Ideal, and we don't have a way to warm in the back of the ambulance,
Yeah, that's
unfortunately,
kinda
but crank up the heat. Giving cold blood is really bad. It increases the incidence of all the complications. That's just unfortunate. In the hospital, we give it over a warmer that's set to 43 degrees.
They could warm it before we go.
Yeah, so the FFP is going to show up basically room temperature because they put it on a warmer. It's stored frozen, and then they
Okay.
bring it up. The blood is going to come on ice. The blood can be administered basically as long as it's on ice, it's still good. And then once you take it off ice, it has to be given in 4 hours. So blood is typically the coldest thing, and ironically, the FFP is warmer because they warmed it up.
Yeah.
The FFP can stay at room temperature because once they warm it, it's done. If you don't use it, they're going to throw it out. So that doesn't matter. But yeah, unfortunately, giving cold blood is bad for everyone, including trauma patients. So everything you can do to actively warm that patient would be a good thing.
Okay.
But yeah, the blood is going to be packed usually in a cooler. If they're really, really anticipating you giving all of it, they might not have the time and they might not put it in a cooler. So the most common thing anyone will hand you is 2 units of ONEG not in a cooler. That's what you're going to get from like an outside hospital. Because
So you don't know when the 4 hours began then, really?
well, you can reasonably assume when you were handed the blood, because if in that scenario you're probably giving it right. So